Hi there and welcome back. My name is Sheldon McLeod. This is Thinking Out Loud. It's presented to you here exclusively on the SaltWire Network. And a big thanks to the team working at our YouTube channel, just getting that up off the ground. And we'd certainly invite you to search out SaltWire on YouTube and like and ding the bell and subscribe and all that good stuff. I really wanted to talk about healthcare because this is something that is touching a lot of us in this province. And, you know, we're fortunate as a family to still have a family physician. Paul Schneiderite recently at saltwire.com wrote this: "Welcome to Nova Scotia. Sorry, we're out of family doctors." Now, he did say, of course, that the headline is exaggeration, and we're talking about, we have one of the oldest provinces age demographic wise, and that in some ways had, researchers asking questions specifically about what is happening. And in the matter, of course, Dr. Ruth Lavergne, who's an associate professor in Dalhousie's Department of Family Medicine and Canada Research Chair in Primary Care, was a co-author of this study, which found that despite there being fewer patient visits, the population is aging, care is more complex, the time spent on care coordination and administration is increasing. So what does this all mean? Dr. Ruth Lavergne is joining us from Dalhousie University today. Doctor, thank you very much for doing this.
Oh, my pleasure.
Tell me a little bit about when the question was asked. When did you decided that this was a research topic that you wanted to dig into?
Sure. Well, it's been a long-standing issue. We all know how challenging it is to find a family doctor or to get care when you need it. So it often comes as a surprise to people that we actually have more family physicians per person than ever before in Canada. And so that question of what explains that gap between a growing number of physicians per person and really persistent access challenges has been something we've been working on for a few years now. But of course, in the context of the ongoing pandemic, it's become even more extreme in terms of people's experiences trying to get care. So we've done this study, which looked at a specific explanation, one that's that sometimes occurs in coverage of the issue of finding a family doctor, and that's that there are generational differences, that more recent cohorts of family physicians are making different choices than previous cohorts, which is something we wanted to look into in depth.
Now, when my children were born, and we're getting close to 30 years now, we had a fairly young doctor, but he had moved into the practice after other physicians retired. Now we're talking the early 90s. So what demographic were you looking at? Which time periods, which provinces were you looking at?
Yeah, so we were able to access health system data in 4 provinces, in Nova Scotia, Ontario, Manitoba, and British Columbia. And those are 4 provinces that have different systems, that have made different choices around primary care. And we're looking over a roughly 20-year period back in time. And so what we're able to do is look at the changes over time across all physicians, and then also look at, as you've observed, as people set up a practice and follow patients over time, their practice changes. So we're able to pull apart the changes that we're observing over time that are common across all physicians, the sort of natural changes over the course of a physician's career, and then anything that's unique to people entering practice more recently. So we're looking through to 2017-18, not during the pandemic period. So is there anything, I think the common narrative is that more recent entrants to practice, or perhaps millennial family physicians, are prioritizing work-life balance and making different choices. And so we were able to see if there were any sort of different patterns in that cohort. And we were actually surprised to see that there were not. We see changes across all physicians, but nothing unique to physicians entering practice more recently.
And how often I've heard that, well, old school family doctors might have a couple thousand patients, but your records, this research looked into up to 2,000 unique patients per year. So it sounds like many of the GPs, the family physicians, are still holding that large a patient role. Is that something that the research backs up?
Yeah, so it's absolutely true that as people progress in their careers, that they see more patients, that the volume of services increases up until a point. And then as folks approach retirement, we see that drop off a little bit. So it's true that when people are entering practice, they work at a slightly lower level. It's just always been the case. That's always sort of been the natural pattern of people's careers. So yes, there are still physicians in practice who maintain sort of a high volume of practice. But what sort of our data supports is that practice is changing for everyone. We also see examples of people in established practice who are making different choices, scaling back a little bit, adjusting how they're working. And there are changes within the population, the system, and the practice of family medicine that impact everyone and help explain this observation of fewer visits on average per physician over time.
So the question, in some ways, you're trying to answer is: are these wives' tales, are these generally accepted facts actually facts? As how generationally doctors entering the field are taking on patient loads. So outside of that question, what were you hoping to find through this study? What is it that you were also trying to answer?
Yeah, so I think we all share the goal of just wanting to make sure people can access the care they need. If we're focusing on this idea that people entering practice are working differently, then that might point us to solutions that target those groups specifically. So maybe changes to training or education. I think what our findings show is that won't actually help us. What we need is solutions that shape the workplaces and practice settings of all family physicians, and that this is really a shared challenge nationally. It's not unique to any single jurisdiction. But there's a lot we need to be doing to make sure that we actually have the capacity to meet patients' needs. And that's, I think, how we would hope findings sort of shape the conversation.
I guess in some ways, recognizing family physicians as a specialty is a way that some jurisdictions are moving. British Columbia is looking at perhaps taking away the fee-for-service or looking at it in a different way. And I know that's been a common refrain through presidents, past presidents, future presidents, I'm sure, of Doctors Nova Scotia, who said that fee-for-service does create some of its own challenges with it when it comes to being able to see many patients, especially as a population ages and as I introduced you, the health care issues are more complex.
They absolutely are.
So where does this take us then?
Okay, so you've mentioned a couple possible solutions. We often go to physician payment, and that's absolutely, that's an important issue. So people have been completing family medicine residencies, and that's been recognized as a specialty since the 90s, but it's often not compensated well compared to other medical or surgical specialists. So the recent step in British Columbia to introduce a new payment model will change how physicians are paid and also do a little bit to address that gap. That's important. Family physicians deserve to be paid fairly for the work that they do and the value they create for health systems. Changing payment on its own, though, doesn't actually get us more capacity in the system. So I think where we also have to point to is changes to how we organize care. Nova Scotia is already doing some of that work, but there's a lot more to do. And that would include how we set up practices. Are physicians working on their own or with broader teams of people that expand their ability to see patients? Are we looking at the way that family physicians are supported with respect to some of the non-clinical work they do? So one of the things that may be happening is there are fewer visits, but people have much more work to do to follow up on referrals, prescriptions, and other coordination within the healthcare system. So we could provide additional supports to reduce administrative burden. Again, some of that work is underway in Nova Scotia, but given the scope of the challenge, we need to do more. And then I think a final piece is family physicians are doing all sorts of different work within health systems. They're providing needed care in hospitals and emergency departments. But we also sometimes see an urge to set up urgent care clinics or walk-in clinics to meet people's needs quickly. And I fully understand that reason, but we're not actually getting more people to do that role. Sometimes we're just taking people away from longitudinal care in the community where they're following people over time. And when people bounce around from different walk-in clinics and urgent care clinics, that can actually create duplication and inefficiency within the system. So what we really need is a focus on community-based primary care, more widespread adoption of team-based models, and adding other care providers to the mix, and making sure that receives the support it needs to really meet people's needs. And then longer term, I think we could be more actively planning for primary care workforce and capacity going forward.
I didn't hear you mention virtual care.
Virtual care can absolutely play a part of it, but it's all how it's combined into the system. If it's a standalone platform where it then falls to your regular family doctor to update your records, we might be just creating more work within the system. If it's well integrated into a clinic where people know you and you're able to access care virtually, then that's ideal for many common health complaints. So it's really a matter of how it's used, not if it's used. Clearly, virtual care has a place in our systems going forward, I'd hope.
This is something that's just been published. The whole idea of scientific rigor is to have it peer reviewed. I'm wondering where that process is, what it is we'll hear to follow up with this report, what it is that you hope to bring to your research next.
Yeah, so given that this work shows that it's not these generational differences, that's a story that's been told, but that's not really what's driving what's happening here. As next steps, I think we want to sort of produce more evidence around what the drivers really are. So those changes in administrative workload, what does that look like and how can we address it? Understanding the nature of changes in the care of the population as it ages and as demographics change. Because it's not simply a matter of people growing older. What we're seeing is that as people age, they also are being treated for more conditions, that they're receiving more active management, more prescriptions, more referrals. So how does that shape required capacity? And bringing that together to try to support governments to plan more proactively and look at both the age distribution of the population, the workforce, and how the work is changing over time in planning for the future. So that would be the goal going forward.
And if I'm government, what's the call to action? What do I take away from your report?
Well, I think the one thing I do want to emphasize is that this is not unique to Nova Scotia, that this is a shared challenge nationally. So it's an area where I hope that there's national leadership as well. I think it's mostly a matter of there are pockets of great work happening around team-based care, around administrative workload. It's a matter of scaling those so that everyone can access a supported team that can meet their needs, whether in person or virtually, and have the expectation that the system will be there when they need it. So I think building on some of the initial successes we've seen so that everyone's experience represents the sort of best possible quality of care in this province.
And if I'm one of the tens of thousands of Nova Scotians without access to primary care, I don't have a family doctor, what do you say for those folks who are looking at this data or perhaps hearing us talk about this? I
mean, I can very much empathize with the situation. I think it is a matter of cobbling together care, and we're really seeing that people without a family doctor are receiving two-tier healthcare. They're not able to access the coordination and referrals that other people have. So it is an urgent priority. So there might be some options. We've seen stopgaps with respect to virtual care and efforts to expand urgent access, but I really hope that we continue to hold governments accountable to make sure that people have a regular source of care that knows you and can support coordination of care over time, and not just these cobbled together options that might actually take more time and resources to deliver without giving you the experience of actually having someone who knows your story and who can coordinate your care over time. And so it's only through building capacity for longitudinal care that we're going to get everyone sort of back in a situation where they have a primary care system they can rely on.
Did anything in this exercise surprise you?
Well, do you know what? I'll be honest, the stories are so widespread and they line up with, pop culture explanations of generational differences. I think many people on the team expected that we would see that to some extent. The extent to which we saw no evidence of generational differences consistently across all 4 provinces came as a bit of a surprise to us. But I think once you think it through with respect to the fact that things are changing for everyone and the broader system changes and changes in how healthcare is delivered just are so much more important than when you happen to be born or enter medicine. So I think once you think it through, it all makes sense.
And anything else that you want to touch on before we wrap this conversation up?
No, I think that covers it. I really appreciate you taking the time to talk through the nitty-gritty of this paper with me.
Well, Dr. Ruth Lavergne, an associate professor in Dalhousie's Department of Family Medicine and a Canada Research Chair in Primary Care. It's an important issue. It's a conversation a lot of us are having, and I'm very grateful for the time that you've given to us to help us perhaps understand a little bit about what's not happening as much as what it is that is driving these changes. So thank you for that.
Thanks so much.